Om Shri Ganeshaya Namaha. Let's start on a positive note.
Good evening, everyone, respected seniors, colleagues, juniors, postgraduate students, and all the participants. I, Dr. Deeptara, welcome you all on behalf of Sorbillon 15th Executive Committee to our second CME entitled Dermoscopy, the Indispensable Bridge Between Clinical and Therapeutic Dermatology, which is accredited with NMC CPD points. Today, we have with us Dr. Siddharth Sonthalia from India, who don't need any new introduction, who is himself an ocean of dermoscopy and going to share with us a few drops of knowledge of dermoscopy with us due to lack of time. I'm sure we'll be having more academic activities regarding dermoscopy under his guidance in near future. And also we have Dr. Bibhu Samatya, who is also a speaker in today's webinar, and he is a well-known to us, and I'm sure this webinar will be a sensitization for our budding dermatologists in the field of dermoscopy. And I'd like to thank Alchem team on behalf of Sorbillon, who has provided us with this online platform and technical support. And one announcement I just want to make before the webinar start, that you can write your questions in the chat box, and if time allows, we will take up your questions. Without wasting time, I'd like to invite our chairperson, Professor Dharmendra Kant, who is an eminent dermatologist and not only nationally recognized but also internationally too, and to introduce our speaker. He is currently affiliated with Dhulikhel Hospital and presently HOD of Department of Dermatology. He has multiple publications to his credit, both in national and international journals. He has many affiliations to national and international society too. His areas of interest are aesthetic medicine, dermatosurgery, and dermoscopy. So without wasting time, I invite Dr. Dharmendra Kant to start our webinar and introduce our speaker. Thank you.
Thank you, Dr. Deeptara. Hello, good evening, everyone. Thank you for being here this evening today. Today, we are pleased to welcome our two speakers, Dr. Siddharth Sonthalia and Bibhu Samatya. Dr. Siddharth Sonthalia, I know him personally for the last 7 years. When I first met him in Udaipur, Rajasthan, conclave, hair transplant conclave, and I was invited as a faculty, and Dr. Siddharth Sonthalia was course director for dermoscopy, where I first got incited to learn about the dermoscopy. Before 2015, I used to use small dermoscopy to differentiate whether it's a malignant or benign. But I learned from him trichoscopy, neuroscopy, and benign, different kind of benign lesions in dermatology. So I have attended 3 or 4 conclave on dermoscopy, which was conducted by him. So frankly speaking, he is my very good friend. He is my teacher and mentor for dermoscopy. So I'm very happy to welcome Dr. Siddharth Sonthalia, a very special guest for us. And this is a third academic guest for him to Nepal. First, it was conducted in Dhulikhel, second in Pokhara, and third, today we are here in virtual meeting. Dr. Siddharth Sonthalia, he has number of publications, more than 175 publications in its credit, and he has got gold medal in 2003 from Delhi Medical Association. He has delivered more than 100 invited guest lectures in different conferences, national and international conferences. He has got various scholarships and fellowships in different organizations. Currently, he is editor-in-chief of Start for Internet in Dermatology, senior associate editor for Journal of Cosmetic Dermatology, and he is former associate editor of JCAS Pigment International Dermatology Therapy, former section editor of IZDBL. He is a member and editorial board in Skin Appendage Disorder and JCT, ICD, and JPDS. He is a founder treasurer of Pigmented Disorder and Society PDS and founder member of Male Society of India. And he works as a medical director and senior consultant dermatologist in Cosmo Laser Surgeon in Skinosense, Gurugram, and director and CEO of Dermasource, India. He is a member and board of director of International Dermoscopy Society. He is chief founder and secretary general of Indian Society of Dermoscopy, Poliscopy, and Trichoscopy. He is appointed as a IDS project director in dermoscopy skin color, and he has conducted more than 75 dermoscopy training CME and workshops in national, in India, internationally. And he has conducted several. He has invited International Dermoscopy Summit liaison in charge for invited dermoscopy training for India, Nepal, Sri Lanka, Bangladesh, Iran, Egypt, Philippines. So I am very much honored to welcome Dr. Siddharth.
My pleasure, sir.
So I will today we'll be focusing on dermoscopy, basics of dermoscopy, and common conditions, how we perform dermoscopy, and what is the inclusion and conclusion. So with that, I ask that you give your full attention to Dr. Siddharth. Dr. Siddharth, over to you.
Thank you so much, sir. I think it was a huge honor, to get invited first of all by Sorvelon. I've had a long history of Sorvelon, and thanks to you, the bond remains as strong as ever, despite everything which has happened in recent times. So, without further ado, I think I will like to directly come to the topic. Okay. First of all, Deepika, I think. For all my colleagues, welcome and thank you so much for joining us today, because learning dermoscopy is no more a choice. Learning dermoscopy is absolutely essential if you want to give the best to your patient, right? And that is what you swore while taking the Hippocratic Oath while becoming a doctor. So to begin with, we have 6 questions which will be projected by Deepika, and all the delegates will have they must participate and they must enter their choice. Even if you don't know the answer, no worries. The nearest answer that you think, the nearest option, it's an MCQ in the form of an MCQ, you must enter, because participation in the pre-test analysis questions and then the post-test analysis questions is not a quiz. It's there is no negative marking, but it is essential for you to get the certificate, which has dual certification, both from the CPD points from the Nepal Medical Council, which Dr. Deep Tara has obtained with great effort, and also the accreditation from the International Society of Dermoscopy, IDS, of which I am a board member. So, should we go ahead? Do I need to share the screen? Deepika?
Sir, I have it here. You can just...
Okay, so first of all, you will be posting those 6 questions, right? Yeah. So which of the following is the most correct figure of the magnification that modern digital dermatoscopes can provide? Which is the highest possible magnification? So it may be a trick question. So just choose which A, B, C, or D. It could be 10x, or can it go beyond 500x? So we have around 10 seconds per question. Deepika?
Yes, sir.
Okay, so please, just mention once the time is done and we can move on to the next poll question. Okay, whenever you see a dermoscopic image, the blue color, in case you are seeing a melanocytic lesion, the blue color indicates that the location of the melanin of the scope lesion is primarily in the papillary or the reticulodermis, the dermoepidermal junction, throughout the layers of the epidermis but sparing the dermis, or stratum corneum with hyperkeratotic corneal layer. That means hyperkeratotic stratum corneum. Where do you expect the location of the melanin pigment to be the highest in a blue colored lesion appearing on dermoscopy? Simple question. Okay. The USB or the USB video dermatoscopes, which like eScope and Dermalite, and the handheld smart dermoscopes like Dermalite DL4, which is one of the most commonly used one, they have their own relative advantages and disadvantages. In what way the USB video dermatoscopes are better than the handheld smart dermatoscopes, excepting one? So does it obviate the need for any contact fluid? Do the video dermatoscopes provide better image demonstration to patients and relatives? Do they provide higher magnification imaging? Or do they allow dynamic and real-time evaluation in contrast to the handheld? So 3 are correct, 1 is wrong. So you have to choose the wrong option, which is not a benefit of the USB over the handheld. Next. In which group of disorders, the dermoscopic analysis may in fact offer a more specific diagnosis over and above histopathology? Now, histopathology is still considered to be the gold standard of diagnosis, of cutaneous diagnosis, but in one group of these 4 disorders, dermoscopic analysis can provide you what histopathology may not provide. So which group of disorders is it? Facial melanosis, nail disorders, alopecia of the non-cicatricial variant, or the cicatricial variant? If you have sent biopsies from one of these, from all these, I'm sure you will get the answer easily. Next. The pseudoreticular pattern of pigmentation is physiologically seen over which part of the human body when examined under the dermoscope? Is it the face? Is it the sun-protected areas of the arm? Is it the forearm, which is sun-exposed? Or is it the mucosal surfaces? So one of them has a pseudoreticular pattern of pigmentation characteristic, whereas others have either reticular or their own specific pattern. So which one? Last, the next one, which has a poll. So I hope all the delegates are entering their answers, right? Are attending the answers. The questions. So all of the following are characteristics of superficial melasma on dermoscopy. See, I'm using the word superficial. I'm not saying epidermal, dermal, or mixed, because that's out of the picture. There's no such classification now. So all the features are characteristically seen in superficial melasma on dermoscopy, except for, that means 3 features are seen, but 1 feature is typically not seen. Brown structureless areas, increased vascularity, perifollicular pigment infiltration, or altered pigment network. 3 are seen or may be seen. 1 is typically not seen. Rather differentiates superficial from deep melasma. So I think we are done with these 6 questions. So I think now I should be sharing the screen from my side, which is yes. Okay. Is the screen visible to everybody?
No, sir.
Excuse me? Yeah, hi. Is the screen visible to everyone?
No. You'll have to click on the green arrow, which is at the bottom.
Yeah, just let me share screen. Okay. Yeah. Okay. I think it must be visible now, right?
But you can just see that I started the screen. Okay, now full screen.
Yeah. So this is just about the topic today. So some of the questions have been covered up. Some of them are left out. So this we have discussed. This Deepika had displayed. Just have a look at this color, right? So this was also discussed, of course, the blue color. Where is it seen? This question has been there, so I won't repeat it. Now, I want you to observe the clinical and dermoscopic features of the centrofacial eruption of this lady, which have been present for the past 1 year, off and on. She uses sunscreens off and on. The scalp examination revealed perifollicular scales. There is history of application of topical steroid mometasone, which was only for 10 days, that to 2 to 3 months back. She was positive for fragrance mix and nickel on patch testing. Obviously speaking, when we are considering differential diagnosis of face over a lady in particular, the patient refuses biopsy more or less. Now, this is the image which is polarized non-contact dermoscopy with DL4 handheld instrument at 10x magnification. And I've removed the lens plate. I'll tell you, we'll discuss why the lens plate was removed. So just have a look. Okay, you can see something, a background, a color, certain structures forming certain configurations, certain whitish structures. I'm just giving you a clue. This is the image from the scalp, from the vertex, which is showing a lot of flakiness. I'm just giving you the hint. So what is the most likely clinico-dermoscopic diagnosis? Is it seborrheic dermatitis? Is it topical steroid damaged face or TSDF? Is it de novo erythromelalgia rosacea? Is it SIRD, which is steroid-induced rosacea-like dermatitis? Or is it a form of primary cutaneous dermatitis, especially the conglobate type? So these are the 5 options that you have, and there is only one dermoscopic diagnosis, but I've still put the word most likely because we should not be very confident or overconfident with dermoscopy, right? Which linkage fluid is most commonly used with for onychoscopy? I think this question was put in which ways. Is it the mineral oil, liquid paraffin, ultrasound gel, or isopropyl alcohol? I'll tell you about linkage fluids. Next question. The following tractoscopic image shows a typical sign of a particular form of non-cicatricial alopecia. And it is considered to be very, very suggestive of an early active case. Just have a look. I think that's a beautiful image. You can see loads of thinned out hair. I think I've given it out. And these are the things which I'm talking about, the white arrows pointing towards the perifollicular area. So am I talking about the yellow dot sign, the brown peripylar sign? Am I talking about the hair powder or the circular hair sign? Which dermoscopic clue is being discussed? This, I think we have discussed that advantage of USB video dermatoscopes over the handheld one, except for, right? Now, coming to the next question, I want you to notice that there is a pattern of pigmentation in the intramammary region of an elderly diabetic lady who had recently also taken norfloxacin for the first time in her life for suspected gastroenteritis. And she also complains of increased itching on sweating. You can see the inframammary lesions, but there are also lesions which are scattered in the surrounding area. This is a polarized non-contact dermoscopy with my video dermatoscope at 150x magnification. If you know it, you know it. This is a giveaway question. There can be only one diagnosis. You can see 3 colors in the background, but the most prominent thing is over the surface. What is the most likely diagnosis? Is it tinea? Is it candidal intertrigo? Is it lichen planus? Or is it a fixed drug eruption? Okay. In this, I think we have discussed this question, that where do we need dermoscopy in adhesive pathology? Now, once again, observe the clinical and dermoscopic pictures of this lady who has diffuse pigmentation, but was also positive for fragrance mix, and the patient obviously refused biopsy. Just see. So this is a very vague kind of pigmentation, clinically appreciable. Dermoscopy with e-scope at 150x magnification in the polarized mode, you can see this. Just see that there is a lot of pigmentation, but the pigmentation is surrounding the white dots. Now, what those white dots are, what does it mean? I don't know right now. Is it evolving melasma, lichen planus pigmentosus, pigmentary demarcation line, or PDL, nevus of Ota, or am I talking about maturational hyperpigmentation? There Observe the feature in a 13-year-old boy who has a hypopigmented lesion and complains of its spread along lines of trivial trauma. I'm talking about co-mineralization. Just see. So these are these small spotty confetti-like hypopigmented macules, and this is the dermoscopy. I have highlighted with the black arrow 2 areas which show something in addition to the whitish areas which you can see in this surrounding. So the most likely diagnosis of this patient is extragenital lichen sclerosis. Is it guttate vitiligo, progressive macular hypomelanosis caused by Cutibacterium acnes, or post-seborrheic dermatitis hypopigmentation? The arrows were characteristic, which are seen only in one of them. I'm showing you 5 pictures. 2 of them are suggestive of the nail psoriasis. So just see carefully. This is 1, 11.2, 11.3, 11.4, 11.5. Don't worry, I know that memory can fail anybody. So you have all of them in one place. So 2 of them are highly characteristic of psoriasis. I'm not saying the others cannot be. So which will be the best to choose for suggestion of psoriatic involvement of the nails? Okay. Now observe the hyperpigmentation of this lady who came from Bangladesh 3 years back, and she has been using loads of things, herbal creams and whatnot, except for a sunscreen. This is the kind of pigmentation that she has. And on dermoscopy, this is the kind of pigmentation, this is the kind of structure that you can see. So this is polarized non-contact dermoscopy, 10x magnification. So in this patient, you would like to try all the treatments which might help, except for one which should not be used. So is it the laser, elixidrite? Is it hydroquinone? Is it dermabrasion, or chemical peeling with TCA? 3 might help. One of them should not be attempted. Okay. A patient with recurrent lesion over the right leg, who has been having it for the past 7 months, has had topical tacrolimus, Candid B, oral itraconazole, off and on here and there. So you can see this lesion, which looks highly modified, and there's a biopsy stage because the biopsy was also done. Remember, I want to bring this to attention to all my colleagues right away. If you plan any study on dermoscopy, please do not exclude histopathology, because as of now, the evidence building and the histogenesis can only be proven when we can measure or compare the histopathology with the dermoscopic tools. This is the biggest flaw, with all due respect, which IDS, International Dermoscopic Society, has been doing, especially with our kind of dermatosis and skin of color. Now, the KOH was non-contributory, skin biopsy was done, and on video dermoscopy, what you saw in that patient was this chaotic thing. Although I found it very, very, very beautiful, and I got it published also. So what would be your best treatment option? I've just given you a 5 treatment options pertaining to psoriasis, tinea, and other things. Just check all the 5, and which one would you like to recommend? Because this is the dermoscopic evidence of whatever I have shown you of the depth. Second, okay, this is done. And the last question, after which we come to the discussion. This is a 16-year-old girl who came to me with scalp itching, and this was what I saw on the initial trachoscopy. You can appreciate the things which I have circled. After 3 weeks, I had given her the treatment for herself, for the entire family, and I'm dead sure that the compliance was fantastic. I still did a trachoscopic reanalysis, which showed picture like this, and this in contrast to what you had seen earlier. So what should I be doing in such a patient? Should I retreat with permethrin, just the index patient, retreat the entire family once again for pediculosis? Advice regarding using diluted vinegar and hygiene maintenance, or the patient needs to be treated with 3 weekly doses of oral ivermectin because she seems to have heavy infestation. So I'm sorry I had to rush through these questions, but the time is less, so that's why. So I think I will leave it here. How many of you are confident that you have something in control, that questions were answered rightly, any which ways. So now I need to stop the share and start sharing my presentation. Just a minute. No. Yeah. Sort the answer. Just one second. Dermoscopy in general dermatology. Yeah. I think this is the one, right? No. Just give me a second. Yeah. Okay. I'll just close the other ones. Yes, I'll close this as well. Okay, so I'm just left with one of them. Right. So no confusions now. Yes. Okay. So we'll rush because I want certain points to be brought across, but then we will try and maintain, the time wrap. I'll request my moderators to please let me know as and when I'm running too much out of time. Okay, so in dermatology practice, it is no more an option, especially given the fact that we stay in that part of the globe where the population in terms of the patients and the therapists is the maximum, but we require it the most. However, the skin of color dermoscopy is being done, unfortunately, by people who do not encounter skin of color patients to that extent, like us. So this is change. Change is inevitable. The problem with people is that we do not understand that change is constant and we always resist it. The resistance comes because of the fact that we don't know what we have to gain and we don't know what we have to lose. And the sheer, for example, the colleagues from South Vallon who are attending this today, they are making an attempt and they are definitely bound to gain out of today's webinar. Of course, this is just the stepping stone. So the prioritization of skin of color is important. Active participation of the countries, the SAARC countries, that's why we started in SARCD in the SAARC nations is important. And with the catching up of reflectance confocal microscopy and OCT kind of instruments, we better catch up. Otherwise, we will be left behind the world, the Western world, far behind. Now, just let me show you from the help of one case. This young girl had 5 to 6 scattered annular macules, which were mildly itchy. There was no sensory issue. Sometimes occasional paresthesias. There was no improvement since on application of fluticasone, which was given thinking that the patient has a tendency of atopic dermatitis, which was the case because she had history of seasonal asthma as well. Just see the lesions. So I would have thought of nummular eczema with an atopic skin in the surrounding plot. I did not even check for anything else, but still I kept a huge list just to complete it for the sake of completion. Now, what do you think it can be? The most likelihood is annular maculopapular lesions of atopic dermatitis. Just have a look over this dermoscopic view. Can you appreciate that there are wide structureless areas? Okay, we'll come to what structureless areas means. Structureless means that they don't have a definition. They are present in any configuration. There are reduced white dots which represent these acrosyringium. Apart from that, can you appreciate that there is a reduced number of hair follicles and the hair shaft is very, very thin? There is mild surface scaling and these xerosis is making these skin creases very, very prominent. Although you cannot appreciate any vascular changes, nor can you see any yellowish brown globules. So you're thinking right. I'm trying to think in terms of the possibility of a lesion of leprosy, of indeterminate leprosy, or leprosy in mild reaction, but it is not a typical yellowish brown which is suggested to be the change on granulomatous lesions. In another area, when I examined, I did see that there was an area of yellowish brownness. Another area, the white structureless areas were more, and the hair abnormality were more, as well as the acrosyringeal openings were almost lost. So we suspected Hansen's disease, and it was corroborated after a biopsy. And the diagnosis was indeterminate Hansen's, but going towards the borderline tuberculoid pole. So this is just one of the examples where the diagnosis, which I kept in the end, was proven to be correct just because I took 3 to 4 minutes of my time with the patient, put the dermoscope, and evaluated the lesions. In fact, I evaluated the photographs not there and then because it is almost practically impossible. You go back, you read, you try to match it with something else, and you try to corroborate it with biopsy, right? So this is what I call as retro-dermoscopy. You are not expected to know everything about dermoscopy of all the diseases because they have not even been charted out, but you keep gaining by making your own diary of collection. Now, this is what you may see sometimes in cases of leprosy of relatively lighter skin types, where you can see the colors of yellowish orange, as well as vessels may sometimes be seen, which are not seen in skin of color. That's why skin of color dermoscopy needs to be studied, evaluated, and taught in a very, very independent fashion. Confirmation with histopathology is must, at least in the current state of affairs. This is my request and to all the dermoscopy enthusiasts, and absolutely necessary to corroborate our findings. Now just have a look at these two patients. Do we need the dermoscope? Not really. The first patient most likely reveals melanosis or lichen planus pigmentosus. The second patient, melasma. There is no doubt about them. This is the patient which I showed you in the quiz. There are a list of possibilities in such patients is long, and one must entertain everything, but the biopsy is not going to be entertained nicely. Of course, a lady, a beautiful lady otherwise, and the face, right? Despite all counseling, he or she will not agree. In fact, even a guy may not agree. On dermoscopy, polarized non-contact dermoscopy with my e-scope, you can appreciate the presence of deposits of brown colored granules and dots which are localized around the acrosyringeal openings. Can you appreciate that? And just see, there's a line. These pigments and their deposits are forming streams like this, right? This is known as the Hemlike pattern and is characteristically seen in lichen planus pigmentosus. Some may call it Reed's melanosis. Some people differentiate the two. I believe that they are the two sides of the same coin. Another picture from the same patient, you can appreciate once again that the clustering of the pigments is basically around the acrosyringeal openings, the white dots, right? So, pigment deposition around acrosyringium with accentuation and a hem-like pattern is characteristic of lichen planus pigmentosus and not seen in any other facial melanosis. What is a hem-like pattern? I'm sure all my colleagues from the superior gender know what a hem is, but for those who are men, I mean from the inferior gender like me, a hem is like a stitch pattern. Okay, so just appreciate. You can appreciate that this is looking something like this. So in dermoscopy, you need to have some imagination, and you need to have, you need to have imagination. You need to know that, yes, you might see it and try to correlate. If you have to really force yourself to correlate, please go back and check what the papers or the evidence in the past has been published, because it might not be correct, which I have on several occasions corrected. uh, against the will of the society. In contrast, if you were seeing this kind of a picture, just see this is just the opposite. There are presence of multiple brown colored clods, multiple brown colored archiform lesions, which you can see, they're forming various configurations. And in contrast to the previous picture, you can see that there is perifollicular as well as periadnexal sparing compared to the other areas, compared to what I showed you in lichen planus pigmentosus. So this perifollicular sparing with presence of brown clots in various configurations is characteristic of melasma. The perifollicular sparing becomes perifollicular involvement in deeper melasma, and it becomes perifollicular accentuation or nodularity with pigment or pigment granulation when it becomes exogenous uchronosis. So this is just to differentiate melasma from LPP, the two most common conditions. Faint to intense erythema and telangiectasias. Please don't think that it is always a sign of topical steroid abuse, because this is also corroborative of the vascular theory, which is the latest theory to the generationogenesis of melasma. So this kind of a comparative chart you can easily avail of from various publications. Now, what is this? Can you see? I'm sure everybody can appreciate that there is that background of pigmentation of melasma. You can see some strawberry colored areas, right? These strawberry colored areas, they signify atrophy of the epidermis and the dermis in particular. And you can see there are blood vessels which are tortuous and branching. This is characteristic of steroid abused face. One more feature, anybody can speak out which is visible to suggest this is from a lady's cheek, which can suggest that yes, there has been steroid abuse. Hypertrichosis, just look at the increased number of hairs which are present, which is not commensurate with what you expect to see. Okay, so this is the atrophic areas, the tortuous blood vessels. This was the patient. So this patient had been applying clobetasol like Fair and Lovely twice a day for the past 2 years, and this is how she was caught, in the sense, for her own benefit. Topical steroid abuse phase. In contrast, what if I showed you this image? Now I showed you this image of a lady who had increased erythema and irritation over the cheeks, right? Just appreciate that in contrast to the image that I showed you here, there are blood vessels, but they are tiny. They are arranged independently in the form of vascular polygons in a background of overall erythema with certain things, with certain whitish colored scales, as well as white colored dots and tails. These are known as demodex tails. The ones which you can see here, these are demodex tails and demodex associated comedones. So this is typically the feature of erythemotelangiectatic rosacea de novo origin. If it was steroid abused or steroid-like rosacea, steroid-induced rosacea like dermatitis, the vessels should have been tortuous and thicker. If it was pure cutaneous primary dermatitis, in that case, the signs of inflammation, papules and pustules should have been really too much, and the vascular signs should have been much lesser. So you can see that there is a reddish colored background. You can appreciate these whitish scales. You can appreciate the follicular plugs, dilated demodex follicular plugs and openings, and you can appreciate the demodex tails. So this is characteristic of ET rosacea de novo. Now, before we come to, so we have just shared 2 or 3 abnormal cases, right? The biggest deficiency in our understanding of dermoscopy is that what's normal, we don't have normograms of what is the normal dermoscopic appearance of, say, type 4 skin of the face of type 4 skin, normal. What about the groin area? What about the neck area, right? So any which ways, I have to go through this and I won't go into the controversy. Remember that what's normal will depend upon these Fitzpatrick skin phototype. What is normal for type 1 may not be normal for type 5 skin. The reticular pattern is present on the entire body except for the pseudoreticular pattern, which is seen over the face. Why? I'll just show you how the reticular pattern forms. Reticular pattern becomes disturbed over the face because of presence of exuberant amount of openings of the acrosyringium, hair follicles, as well as the sebaceous glands. So the glandular openings make reticular pattern pseudoreticular over the face. The mucosa, once again, what is normal may not be abnormal for the skin. So just see, this is, I'm sure you all might have seen this diagram. This is a schematic diagram which shows how the pattern of the epidermal papillae and the dermal papillae and the epidermal literages forming alternately, and the position of the melanocytes gives rise to alternate hole-like appearance or net-like appearance, in which the areas which are devoid which have less melanocytes appear whitish, whereas the other areas appear darkish in color, and that gives a net-like appearance. So this is a normal reticular pattern. Reticularity, I'm sure. This is another image from my own forearm. This is, as you can just see, the reticular pattern has changed into a pseudoreticular pattern from the face because of the presence of openings of various glands. Same here. Okay. What is the difference between 10x and 10x? The first one is also 10x, it's a hand lens. The second one, which is 1.5 lakh rupees or something, I mean, say whatever dollars kind of an instrument. So how does this differ from a hand glass, from a hand lens, when the magnification is only 10x in the DL4 dermalite, which is the most commonly used instrument? Well, it is not the magnification along the XY axis, it is the magnification along the Z axis. That means it allows for the evaluation of the subepidermal structures through either the polarized light, use of polarized light, or by application of a linkage fluid, which enhances the optic coherence or which enhances the translucency. So this diagram simply clears the basic concept of how does a dermoscope work. Whatever light is incident over the skin, a huge amount of it is reflected. Some of it gets refracted, some of it gets diffracted, and some of it gets absorbed. The reflected light which reaches our eye can be made to go through two cross polarizers, and this is what polarization is all about. The reflected light becomes monochromatic by the time it reaches the eyes because of these two cross polarizers. I'll show you. Polarization is a concept which you must clear out right away because it always creates confusion. It took me 5 years to understand what really polarization and non-polarization meant. So this is how when you're using a glass, you have an image on the left side which shows a non-polarized image, and just compare it with the right side, which has a definitively more clarity because the peripheral rays which are causing a lot of glare have been cut off. This is precisely what this does. That means the polarizer cuts off the peripheral rays and allows the visualization of these epithelial structures even without a contact fluid. Therefore, we can have three kinds of dermoscopy: non-contact polarized dermoscopy, polarized non-contact dermoscopy, and polarized contact dermoscopy. So most commonly we do non-contact polarized dermoscopy when we have a polarizer. Most of, rather 100% of the new dermoscopes, whether handheld or video dermoscopes, they have a polarizer. However, sometimes the polarization effect can be further enhanced by addition of a linkage fluid, and this holds true till date, especially for onychoscopy, in which we do what we call as a wet onychoscopy, because application of an ultrasound gel enhances the appearance of the nail plate, the structures beneath the nail plate, because nail plate is a very, very thick form of epidermis, so to say. does the magnification make any sense? When I'm talking about 10x of derm light and I'm talking about 500x of my video dermoscope, I'm talking about the XY axis, right? So far as the penetration into the the Z axis, which that means into the skin, the substratus structure is concerned, that is equal in all these dermoscopes, which reaches 1.3 millimeters of a normal skin. Now that 1.3 millimeters can be increased to 2 millimeters of evaluation with the help of newer instruments like RCM and OCT. So this was just to show you a comparison of how things can be differentiated, right? So you can see that I was not just trying to show you two images and trying to say that this is rosacea, this is Mr. Abused face. There are clear-cut differences. Let's see one more case. So a carpenter of occupation who presented with this kind of a nail, of course, clinical diagnosis is quite clear. The patient also gives complaint of joint complaints with having taken 15 milligrams of methotrexate and sulfasalazine. That means suggestive of possibly either rheumatoid arthritis or psoriatic arthritis, right? He also has flexion deformities in his hands and his feet. Family history of late onset psoriasis also present. So the nails, the X-rays also show changes, including the reduction in the joint space. When you perform the non-polarized dermoscopy and polarized contact dermoscopy, which I'm showing here of the nail, now this gives you the clue. What you can see, this is under the ultrasound gel. You can appreciate the shininess over these surfaces because of the ultrasound gel, which is forming a light surface. Can you appreciate that, number one, the margins from the distal aspect are jagged. They are going like this, like this, okay? And there is a kaleidoscope of colors, very dirty colors, of course. So, but this is the nearest that I could see, which can be called as the aurora borealis pattern. So the jagged margins, aurora borealis pattern, are characteristic of onychomycosis, whereas in psoriasis, you would see more of nail bed changes, which present in the form of increased erythema of the nail bed and in the form of nail play changes like pitting. So when I do a onychoscopic evaluation, I'm just picking, things to keep them, to ensure that they remain interesting. Onychoscopic evaluation, which has gained a lot of ground in recent times, including something known as intraoperative onychoscopy, which all of you should very soon become an expert with. You should always do any evaluation, forget about onychoscopy, but any dermoscopic evaluation should be done starting from the non-polarized mode and low magnification, then enhancing the magnification, and then shifting on to the polarized one, then finally the wet dermoscopy in case you need a linkage fluid, right? Always follow this pattern because non-polarized can sometimes give you certain clues. The surface clues are more prominent on the non-polarized dermoscopy, whereas the deeper clues are seen on polarized dermoscopy. So this is the zigzag-shaped distal onycholysis. And these are areas of whitish collection, which are suggestive of polydermatophytoma. And this color is what we call as aurora borealis. So, of course, the above two are beautiful aurora borealis. The near low one is not that good. Okay. So, next. How many of you, I'm sure all of you must have seen such cases, this, and often sent a biopsy with the pathologist sending you back the report that consistent with cicatricial alopecia, please correlate clinically. All work done, effort goes to the waste. This is very, very typical of cicatricial alopecia. So you should know that in cicatricial alopecia, not only does dermoscopy directly help in the diagnosis, but it also can be used to mark the area where the diagnostic yield by histopathology can be maximized. Because said and done, whether it is lichen planus, lichen planopilaris, the DLE of the scalp, it is going to show something very similar with overlapping features. So these two conditions are often confused and they need to be differentiated, and histopathological findings do not distinguish. So this is once again an answer to the quiz that in cicatricial alopecias, dermoscopy has a special role over and above the histopathology. Now, many of you, I'm sure, including myself, we have aesthetics to take care of. You would be interested to know and very, like hopefully excited to know that aesthetic dermoscopy is on the roll. We are discovering, my team is discovering and publishing loads and loads of uses of dermoscopy directed towards aesthetic, both in terms of the diagnosis as well as the improvement to be shown to the patient and the plan of action. I'll just take one example here, like periocular hypermelanosis or under eye bags. Let's not talk about the pigmentary demarcation line. We know that it can have an epidermal pigmentation component, it can have a vascular component, and skin laxity with muscle herniation is often present in all of them. What I want to differentiate is between the first two, which one is more predominant, because the first one will respond to depigmenting therapies, the second one will respond to therapies targeted towards the enhanced vascularity like vitamin K and rutoside, etc. So just have a look. These three different patients. So the yellow areas are the ones from which I did the dermoscopy. So the first one, yeah. So the dermoscope from this area showed only pigmentary changes. There is evidence of mild edema in the form of pockets of white areas, but there is hardly any vascular change to be commented upon. In this patient, on the other hand, who has in fact grade 2 tear deformity, from the same area, we saw that there is an admixture of not only those pockets of swelling in the form of those whitish structureless areas, but you have a vascular component as well as a pigmentary component, both. Whereas in this lady, we have both the components of equal amounts to the equal extent. Compared with this, where the vascular component is predominating and the pigmentary component is mild, whereas here it is a complete admixture. So this can help you decide what kind of treatment protocol might help in something which was difficult to treat till now, which is periocular hypermelanosis. I use my dermoscope for every patient who's on laser hair reduction to determine what is the extent of scattering, the diameter, and the pigment reduction, so that I can decide on the parameters also. Okay. Now, this, for example, in this condition, this is basically not really periocular hypermelanosis because of a cosmetic issue. This is periocular acanthosis nigricans, and it showed this kind of a arrangement in which you can see alternate areas of dark and white blobs or clots, which is something like the hills and valley appearance which you tend to see in the acanthosis nigricans of the folds. Now just have a look, what are the other uses where dermoscopy is important and very, very helpful. This is one of my patients of lichen planus pigmentosus. This is after phenol peels. I did 6 to 8 sessions of phenol peels. Can you appreciate the improvement? I can, and my staff could, but the patient did not, which was surprising. And my heart went out in the sense that now how do I convince the patient when the clinical photograph is also not acceptable to her to that extent? This is substantial improvement for a condition which is as difficult to treat as LPP. Another patient. So this is after 2 sessions. Now, when I did a dermoscopic evaluation of the same spot, so you have to ensure that you do it for the same spot when you're comparing the pre and the post-treatment dermoscopic changes. So this was the pre, I'm talking about the first patient, and this was the post. So despite the fact that the clinical picture was sufficient enough for me, my clinical staff, and the relatives of the patient to convince her, but this conversion, this differentiation was more added on to my credibility and the patients having been convinced. Just see, this is the improvement of the second patient after having completed 8 sessions. And I could hold on to this patient only by keeping a chart, a progressive chart of the dermoscopic improvement and showing and sharing with the patient on each visit that yes, the improvement is there, even if it is not visible macroscopically, it is visible dermoscopically. So herein lies the importance of dermoscopy in every patient with respect to treatment protocol. You can appreciate that this is in case of melasma, the pigmentation of that area has changed from left to right. However, new areas or new islands of pigmentation have started appearing. Similarly, in vascularity, this patient had received tranexamic acid. There is definite improvement. Okay. So demonstrating post-treatment improvement to me and to the patient is emerging as a standard, not only in personalized clinic, but as in clinical trials as well. And soon your clinical trials, as associate editor and as a reviewer myself, I would always insist rather reject your paper if you do not do a dermoscopic pre and post comparison. But that's me. There are, it's not absolutely essential, but it definitely will be helpful. Now, dermoscopy is also helpful in evaluation of the disease activity, right? I can't go into the details of this, but these are certain signs which we have published in vitiligo. Similarly, in alopecia areata, when you have a patch where you give intralesional corticosteroid, the disappearance of the black dots and the reduction in the increase in the number of active regrowing hair, they indicate that yes, the TC or the topical steroid has been effective. Okay, so just see, this is perifollicular depigmentation, which suggests stability of the disease. This is what we call as the polka dot sign, or the sabudana sign, which is present in the normal skin of patient. So always examine the lesional as well as the perilesional skin in any patient of vitiligo, because if you see this kind of a pattern, this indicates high activity and need for immunosuppressants as well as phototherapy in due course of time. This is macrocognition, this is known as the comet tail sign. And yeah, this is this. I'm just finishing. 5 minutes, yeah.
Reminding for 20 minutes left.
I'm sorry?
20 minutes reminder, 20 minutes.
Yeah, yes, sir. Just give me 5 minutes. I'm just winding up. So this is the comet tail sign. Okay, alopecia areata, I've already mentioned that these are the signs, like you can see the exclamation mark hairs. Once they reduce, that indicates that the activity is less. So this is what I was talking about yesterday, dermoscopy. Once again, the LHR, this is at the baseline. This is after 2 sessions. This is after completion of 6 sessions. So I helped me in deciding the parameters as well as satisfied the patient on objective evaluation, right? So this is what I call as cosmetic WOT mapping, in which in case a patient, of course, now I use immunotherapy in such patients, but you can ensure that even a hidden lesion is cauterized with the help of whatever cautery measure that you're taking. For example, after cautery, I saw that there was one lesion present over the left side, which was left to be cauterized. Okay, this is anybody? This is acanthosis nigricans, which shows typical Hills and Valley pattern. I'm sure the next speaker is going to be covering that. And hair transplantation, the list is endless. And I'm finishing with this, that hair transplantation is one of the areas where trichoscopy needs to be evolved, and Dr. Karan is the best person to do that. I'm sure he's doing that already. I won't go into the details. Last but not the least, we have the cultural significance of this condition. This is the last slide. When I was an intern, and when you guys, my colleagues, were interns, do you recall that if a patient would come with stomach ache, do you put the stethoscope over the abdomen? we were told to put it, irrespective of whether it made any sense or not. Of course, it is important only to see for the vowel sounds in case of a case of obstruction, but the patient feels that he has been taken care of. So the use of a dermoscope on a patient not only increases the faith of the patient and the relatives, but it increases the overall feeling that yes, this doctor is doing something different and he's taking care of me. This is just a revision of all the use of the dermoscope which need to be explored by all of you. I have just given today an introduction to what all things can be done. The scope of the dermoscope is endless, but we have to form this alliance which targets the skin of color. Thank you so much for bearing with me. I had to rush through the slides, but I think I have been able to transcend some information, some facts, and of course, some points of teaching, some take-home messages. How to study dermatoscopy? It has to be retro-dermoscopy. That means you buy a dermoscope, don't wait for it. You buy a good textbook, or there is a website by the name of Dermoscopedia, and you record the images from every patient, corroborated with histopathology or clinical diagnosis if it is clear-cut, and make your own library. That is the only way to learn. Of course, attend these training sessions which Dr. Karan, Dr. Deeptara have been organizing. This is going to clear all your doubts from, so to say, tiny, small time experts, so to say, like me and my team. Thank you so much for the patient hearing. And as usual, I exceeded my time. Sorry, sir. Sorry for that.
Thank you, Dr. Siddharth, for a wonderful presentation. Now, post-test will be performed after the Dr. Bibu's presentation. Now, I would like to invite Dr. Bibus. Dr. Bibus Amate is working as a consultant dermatologist in Pek Nepal Kirtipur Hospital. He is heading the department, and he has more than 25 publications in his credit. And he has published 2 books. Congratulations, Dr. Bibus. He is the author of 2 books, Handbook of Facial Melanosis and Dermoscopy Atlas of the Facial Melanosis. Wonderful. Congratulations, Dr. Bibus.
Thank you so much, sir. Thank you so much.
Over to you.
Okay. Good evening, respected invited speaker, Dr. Siddhartha Sonthalia, Chairperson, Professor Dr. Dharmendra Karna, President of Sortvellan, Professor Dr. Sabina Bhartrai, and moderator, Associate Professor Dr. Deeptara Pathak, and all the members of the audience. I would like to thank you for giving me this opportunity to speak on this topic. Disclaimers first. I'm not an expert in dermoscopy. I just happen to be a simple dermatologist on whom mercy was showered so that I was able to receive the International Dermoscopic Society Research Seed Grant 2019. This work is a direct result of that grant. And as the study was conducted during the pandemic, I had to bribe a lot of people to get the required sample. People were very reluctant. People were very reluctant to come to the hospital and even more reluctant to remove their masks. Second, my picture on the left on the leaflet was taken more than 6 years back. So I think I can just Googled my name and got that picture from the internet. That's not how I look now, as age has definitely taken its toll on me. Third, I've structured this presentation in alphabetical order, starting with A and finishing with V. And finally, I acknowledge all the dermatologists, especially Dr. Siddharth, who have worked on dermoscopy and published their findings. And Smita ma'am, who helped me with the interpretation of the images. She's right now in Canada. So if there is anything good with my talk, then all the credit should go to all the authors who have worked on dermoscopy and published their findings. And it has been a reference to me. And if there is any deficiency in this talk, then it is solely and wholly down to me. So I'll start this presentation, hoping that the right words will come out at the right time, in the right mood. So I've gotten 15 minutes to talk on this topic, and I have around 35 slides. So I'll be giving maybe up to 20 to 30 seconds for each slide. The first, here in this slide, we can just see a structureless hyperpigmentation with some background erythema. As the name, as we are starting with A, so this is post-acne hyperpigmentation, and the underlying erythema suggests that the preceding event was an acne and not some trauma or any or burn that caused the hyperpigmentation. This one, now Siddharth sir has talked about this pattern. It's a hem-like pattern of pigmentation, a bluish gray pigmentation forming a hem-like pattern. Now, this is very characteristic of ashy dermatosis as well as lichen planus pigmentosis. Now the gray-blue dots over a bluish background, these correspond to melanin-laden macrophage or melanophages in the deep dermis. There's this thing called the Tyndall effect. Now, looking at the literature, people have come up with an appearance called the Wagyu beef-like appearance. Now, Wagyu beef-like is supposed to be a very premium sort of beef where there is pigmentation in the crista cutis and absence of pigmentation in the sulci cutis, leading to a Wagyu beef-like appearance. But premium beef is probably a healthy, happy living cow. Now this one, Siddharth sir also had to show this picture. Now this is a blue nevus. Now I've come to B. So this is a blue nevus. Here we can see a homogeneous bluish pigmentation. And the characteristic phrase that is used for this pigmentation is a steel blue color. Now steel blue color is very suggestive of a common blue nevus. Now, if there is an hypochromic center, if there is hyperchromia in the center, then we think about cellular blue nevus. And if there is a black lamella in the center, then it could be a blue nevus combined with other nevi, forming a compound nevus. This one was taken from my chin. I have a cafe au lait macule on my right chin. I've talked to my parents, I've talked to my wife about getting it removed, but they have always suggested against it. So here we see dark brown dots, as well as a reticular pattern of pigmentation. Now, I don't know whether you'll be able to appreciate it or not. The literature says that the follicles, there should be some perifollicular hypopigmentation in cafe au lait macules, but we were not able to appreciate that in this picture. The fourth one. Now, this picture, I came across just one study looking at this picture. Here we can see a coppery red background with pigmentation, dark brown to blackish pigmentation that is accentuated along the skin folds. So this is a clofazimine-induced pigmentation in a person diagnosed with leprosy who was taking clofazimine. Clofazimine is an azo dye that leaves a reddish, dusky red pigmentation. So this is clofazimine-induced pigmentation. This is, there has been just one paper that has looked at clofazimine-induced pigmentation. This one. Now this is very, very common. This is a very common case. This is a compound nevus. With a central hyperpigmentation and peripheral areas of reticulation. So central homogeneous hyperpigmentation with peripheral reticular areas. This is the most common finding of compound nevus. But apart from that, there may be a diffuse or patchy reticular pattern. There may be peripheral reticular with central hypopigmentation. There may be globular pattern or a homogenized pattern as well. Now I've come to D. So here we can see a structure that is basically pale to skin colored. So whenever it's a skin colored lesion, we think of an intradermal nevus. And intradermal nevus, in an intradermal nevus, the nevomelanocytes that have actually ingraced, gone deeper into the dermis, so that pigmentation is usually not visible. And in this, not seen in this picture, but a common finding in intradermal nevus is a cobblestoning pattern. Basically, cobblestones are globules which are slightly separated from each other. Globules which are slightly separated from each other gives a cobblestoning pattern, while globules that are aggregated lacks cobblestoning. Now, she's my mother. She has lots of tiny black lesions on her bilateral malar region. I mean, I've always seen her face, and I thought these were probably lentigo simplex, and I always told her that nothing can be done about these lesions. But as soon as I got my dermoscope, the first thing that I did was I tried it on myself, I tried it on my parents, I tried it on my wife, and this was what emerged. So it was an eye opener for me. This was what emerged. It was an eye opener for me. So here we can appreciate some cerebriform pattern, fissures and ridges with moth-eaten borders. Now, I actually do not like to use terms that are not approved by IDS. So moth-eaten border, it's descriptive terms like moth-eaten border or Hemlike pattern of pigmentation or Wago beef-like appearance. These are not terms that are approved by the IDS, but still, it has been in use for some time now. So, a cerebriform pattern with moth-eaten border suggests dermatosis papulosa nigra. So, what I did was I brought my electrocautery and I removed them, and now they're gone. So now this one, I'm still sticking with D. This is a picture of discoid lupus erythematosus. This is a picture of discoid lupus erythematosus. Here we can see these tiny white spots. These are areas of follicular plugging. So these are keratotic follicular plugs. Interspersed white structural areas. As this is in the face, this is not a typical reticular network. I think as we can appreciate some reticulation on the left hand side at the 6 o'clock position. So this is pseudo reticular network. Now she's my wife. You can see some freckles on the bridge of her nose and on her malar region. She's with my dog. He left us about a month back. So she had these freckles or ephilides, and ephilides they're very they usually show a reticular dark brown to light brown reticular pattern, with again moth-eaten edges. Sometimes a homogeneous pattern can also maybe observed. In fact, most of the literature have said a homogeneous pattern is usually noticed. So now this picture, now I'm moving to H. Here we can see purplish, bluish gray globules. These are interspersed, bluish gray globules, which are interspersed, forming a speckled pattern, and lots of terminal hair as well. So she had been diagnosed, the person from whom I've taken this picture, she had been diagnosed as suffering from melasma, and she had also used some amount of topical steroids. But we firmly concluded that this was not melasma, it was acquired bilateral nevus of ota-like macules, also known as horis nevus. One another finding that can be seen in horis nevus, not seen in this picture, is 4 dots clawed. 4 dots clawed is not characteristic of horis nevus. It can be seen in other conditions as well, but the literature does say that 4 dots clawed can be seen in horis nevus. This is taken from my forearm. A reticular pattern with moth-eaten edges, and the color is slightly on the darker side compared to affiliates, compared to freckles, where in freckles the color was slightly light brown or just tending towards dark brown. But here on the left-hand side, we can appreciate darkish brown, almost going towards black. So this is a junctional nevus, where the pigmentation is, where there is increased pigmentation on the dermoepidermal junction. Now, this one looks like freckles. This one looks like freckles. It has moth-eaten borders like freckles, but the pigmentation is more intense. The pigmentation is more intense. So this is the lentigo-simplex. Now, Siddharth sir had said that nowadays we don't classify melasma into epidermal, dermal, or mixed. We just classify them as superficial or deep-seated melasma. But my fault. I'm sticking to the older classification. Now, over here, this is an epidermal melasma where we see scattered light brown reticular areas as well as globular patterns. So this is called a light brown reticuloglobular pattern. And an epidermal melasma is typically characterized as having scattered islands of light brown reticular network with few globules. When the color becomes slightly darker, like on the left-hand side, we can also appreciate some tiny dark brown dots. Arcuate structures on the 5 o'clock position, as sir mentioned, and telangiectasia in the center. So this is a dermal melasma, and some amount of topical steroid was also applied, as can be seen by the increased number of hair and thinning skin and telangiectasia. But telangiectasia can be present regardless of the application of topical steroids. Now this one, it has features. It has dark brown reticular pigmentation as well as light brown reticular pigmentation with telangiectasia with terminal hair. So this is a mixed melasma. Now, what I had done in my study was I tried to look at the correlation between Wood's lamp and dermoscopy in the classification of melasma and melasma with topical steroid-induced rosacea-like dermatitis, and there was 100% concordance rate in epidermal melasma and epidermal melasma with steroid-induced rosacea-like dermatitis, but that rate fell down to less than 50% in dermal and mixed types. Now, this is epidermal melasma with steroid-induced rosacea-like dermatitis. I'd actually gone through sir's study on topical steroid dependent face as well, just to see whether I could see a pattern, whether I could see anything. So here there is light brown areas with telangiectasia, and I don't know whether you'll be able to appreciate it on the diamond shaped cursor or not. That light brown areas, sorry, the dilated tortuous vessels, they have formed a polygonal appearance. The vessels are interconnected, forming a polygonal appearance. It will be more clearer in the next picture. Okay, the diamond shows the telangiectasia, while the circle, the oval shape shows dilated tortuous vessels forming a polygonal appearance, like a mesh, like a network. So this is very characteristic of topical steroid induced rosacea-like dermatitis or topical steroid dependent phase. And in topical steroid dependent phase, one additional finding that we can that is seen, that sir mentioned, was white structureless areas which correspond to epidermal atrophy, not seen in this picture. So this is a picture of mixed melasma with topical steroid induced rosacea-like dermatitis. Darker pigmentation in the upper left hand corner, while lighter pigmentation towards the center. Now, I'm coming to O. This is N. This is nevus of Porta. Now, the funny thing was, in nevus of Porta, the studies that I referred to, they showed 4 dots claude was very common in nevus of Porta, and the pattern that suggested was structureless areas forming with a gray structureless areas in a patchy distribution. But that's not what I saw. What I saw was actually not very clearly seen, but we can still appreciate curvilinear pattern of pigmentation curvilinear pattern of pigmentation on the 2 o'clock and 1 o'clock and 2 o'clock position. Now, when I looked at the literature that had studied nevus of Ota, they had not mentioned this finding. They had not mentioned this finding. It was published in Our Dermatology online. You can look it up in the internet. And but I looked at their picture and I could appreciate this curvilinear pattern, but they had not mentioned that in their text. So basically, our eyes can see only see the things that our mind knows. I mean, so I'm a practicing Hindu, so maybe I can see an Om somewhere, and a Muslim may not be able to see it. He may see a form of, he may see Allah or Bismillahir Rahmanir Rahim. So the eyes basically see what the mind knows. The eyes can't see what the mind does not know. Now this picture is not very typical. This put me in a lot of diagnostic confusion. So clinically, we were very, very sure that this person had a speckled lentiginous nevus or nevus pilus, but the underlying tan area or tan background was missing. So a speckled lentiginous nevus is called a melanocytic garden. Speckled lentiginous nevus is also called a melanocytic garden because there is an underlying tan area, and on top of that there may be a junctional nevus, a compound nevus, or a Spitz nevus. So here these focal collections, they are suggestive of maybe a junctional nevus with showing a reticular or pseudo-reticular pattern, but there is no underlying tan macular pigmentation. And this actually put me in a lot of confusion, and I discussed it with my senior colleagues as well. And clinically it is speckled lentiginous nevus. So maybe there is something wrong with our technique. So now this is peribuccal pigmentation of Brook. Here, the pigmentation is increased or accentuated along the skin folds. Peribuccal pigmentation of Brook, where the pigmentation is accentuated along the skin folds with a sharp cutoff from the surrounding skin. So basically, the upper 40% of the screen shows pigmentation, while the lower 60%, there is absence of pigmentation. And this is very, very characteristic of peribuccal pigmentation of Brook. We could not appreciate areas of erythema that has been mentioned in studies done in the West. And in one study that we had done at Nepal Medical College, we actually suggested that maybe peribuccal pigmentation of Brook is not a disease. It's not a diagnosis. It's just an accentuated pigmentary demarcation line. Now this one, this is a mixed type of periorbital hyperpigmentation. Here we can appreciate pigmentation, exaggerated pigmentation along the skin folds with speckled globules, and the portion over here and on the right hand side, they suggest some underlying telangiectasia. So we thought that this was a mixed type of having both a vascular as well as a pigmentation type of periorbital hyperpigmentation. Now this is post-inflammatory hyperpigmentation. Post-inflammatory hyperpigmentation is very, very non-specific. There may be a structureless pigmentation, there may be a reticular pigmentation. The pigmentation is usually accentuated along the skin folds. Here, there is decreased pigmentation over the center, while the periphery shows hyperpigmentation. And this is very, very non-specific. This person had a trauma 19 to 20 years back, and the pigmentation was very pronounced on clinical examination. This one is very easy. This is a picture of a seborrheic keratosis. We can appreciate milia-like cysts. The white areas are milia-like cysts. The darker areas, now there is some confusion. Maybe Siddharth sir can enlighten us. Some authors have said that these dark areas are omido-like openings, these dark areas are comedo-like openings, while other authors state that these are simply exaggerated fissures and ridges. Another picture of seborrheic keratosis. Here, milia-like cysts are not appreciable, but we can see those comedo-like cysts as well as moth-eaten border and fissures and ridges. One of our students, Dr. Priya Bhusal, she had done her thesis on dermoscopy of seborrheic keratosis, and I don't think she in her study. Yes, sir.
Can you limit your presentation in 5 minutes, please?
Less than that, sir. Just two more minutes. Thank you, sir. Okay, now flat seborrheic keratosis can be flat seborrheic keratosis. This is a picture of flat seborrheic keratosis. We can appreciate some dark brown dots and some fingerprint-like structures, especially towards the 3 o'clock position. Fingerprint-like structures, especially towards the 3 o'clock position. Now, the thing about a flat SK is that we do not know whether solar lentigo is an independent entity, or maybe it's a flat SK progressing towards an SK. So this is my father. We thought that he had a seborrheic keratosis. We thought that he had a seborrheic keratosis. We did his dermoscopy, and here we appreciated fingerprint-like structures, especially at the 2 o'clock position, with structureless pigmentation, some signs of photo damage. So Smita and I, we spent about 2 to 3 days just tearing our hair apart, thinking whether solar lentigo is the same as a flat seborrheic keratosis, whether they're two distinct entities, or whether whether solar lentigo is a disease in progression that is progressing towards seborrheic keratosis. The last one, I've come to V. So this is a varicose epidermal nevus. We can see a cerebriform pattern, but the characteristic feature of a varicose epidermal nevus, I really had to train my eyes to notice them, are these circles, these brown circles towards at the periphery on the 6 o'clock position, brown circles having a hyperchromic brown edge and a hypopigmented center. These are hyperchromic brown edge and hypochromic center that corresponds to papillomatosis. So I conclude my presentation. I would like to thank all of you. To start my video. So I conclude my presentation. I want to thank all of you for allowing me to present. Thank you so much, sir. And the mic is yours, Dharmendra sir.
Thank you, Dr. Beavers, for wonderful presentation. Now I would like to invite Dr. Siddharth to do post-test and pre-test
yes,
video.
sir, if you allow, I think let's first finish off the answers of the quiz.
Okay,
and then 2-3 comments which Dr. Vibhush has raised, I would like to just clarify them.
Sure. We are running a shortage of time, so okay, so we'll please first answer questions.
Sir, we have time, or we are running behind time?
Oh, actually, it has to be finished by 7:30.
Sir,
now we're
10 minutes more. I'll finish everyone. I mean, not everyone. I'll finish.
okay, no problem.
Okay. So can we have the poll answers?
1 second.
The questions. The 6 questions which were poll bound.
Sure. Arvind?
Yeah. Can you project them onto the screen?
Yeah. We'll screen share. Arvind, screen share kar do.
Okay, so the question was regarding the maximum possible or the the kind of magnification that one can reach with modern digital dermatoscopes. So the answer is 500x plus. In fact, I have my latest video dermatoscope can go up to 1000x. So I think 150x was a trick question. It was a trick. Many people perhaps fell into that trap. So any which ways, 10x is definitely not the one. 10x is the least possible magnification. Okay, so can we go on to the next one? Yeah. So this was with respect to the advantages of video dermatoscope over handheld, except for the answer here should have been A. I can't see A. Okay, yeah. That is, it does not see a video dermatoscope versus a handheld dermatoscope does not have any issues with respect to the contact fluid, because if you have polarization, then a contact fluid is in each ways in more or less cases nullified. So it does not offer the advantage of not having a contact fluid, because DL4 derm light, for example, does not need a contact fluid in standard polarized dermoscopy. Otherwise, all the other 3 points are definitely of much more use. And I think, so this is one which got the highest marks. So this is a good development. Can we have the next one? Nice thinking. Okay. So this is a very important thing that people, that all my colleagues, they kind of mostly understood, that the blue color indicates, gray color indicates papillary, blue indicates reticular, grayish blue would indicate papillary or reticular junction. So that's why I kept it a little diplomatic, so that you could answer A, which was the correct answer. Next one. Okay, so this was also a giveaway. Face is the most common, say face is the site where we tend to see seroreticular pattern because of the increased number of the appendageal openings, both sebaceous, acrosyringeal, as well as the vellus hairs. Next one. Yeah. So all of the following are characteristic of superficial melasma. So as we discussed, that the perifollicular pigment infiltration should not be seen in superficial melasma. That's why I did not use the word epidermal mesodermal. As we go deeper, the pigment infiltration starts to come. So I think these were all the questions that we had put for the poll, and I'll just in the next 5 minutes discuss the post-test analysis of this one. Am I sharing it with you guys?
1 second. Arvind, stop our screen share.
Yeah. Can you see the screen?
Not yet. Yes.
Right? Okay. So,
you want us to start the second poll, sir?
I just finish it off immediately. So this we know the answer is this. So blue color, question number 2, the blue color, this indicates this level which we have answered. Now it's showing you this 40-year-old female patient. So the answer with discussion from Dr. Babush as well as my discussion has shown that this would most likely qualify for de novo ET rosacea, because in steroid-induced rosacea like dermatitis, you will have changes of tortuousness of the vessels and more branching of the vessels, right? What linkage fluid? Very easy, ultrasound gel or the ECG gel, that is the preferred thing. Yes, now this is something which I did not, of course, cover because this is left for all members to read. So this is the traditional brown peripallar sign, which is considered to be confirmatory of activity in androgenetic alopecia in both the genders. However, this is also one of the areas of contention which I have raised, because this sign, in my opinion, should also be seen in alopecia areata because of it stems from the perifollicular infiltrate. In that case, alopecia areata lesions should show it more. Having said that, the traditional conventional concept is that this is the BA50 sign seen in AGA. Okay, so this we have already answered. That is, that does not offer the advantage of removing the need for a contact fluid. The diabetic lady who had these lesions which look like intertrigo. So what you can see is a background of both brown structureless areas pinkish red or crimson red areas, and there is a stacking of Wickham stria. So you can see Wickham stria can have multiple patterns. They can be rounded, they can be reticular, they can be stacked. This shows the stacked pattern of Wickham stria. Apart from that, you can also see multiple granules, brown color granules, brown to bluish gray granules, which shows that the pigmentation is going deeper, and this will heal most likely with PIH. So the answer is active lichen planus. This we have already discussed, cicatricial alopecias. Then the lady with the diffuse pigmentation. This was classical lichen planus pigmentosis. Now I do not believe in going into the detail of ashidermatosis versus EDP versus lichen planus pigmentosis versus Reed's melanosis. This coffee versus toffee, war has always been there, and I'm sure histopathologists will never let it end. So let it be. We are concerned with the treatment options for the patient. Anyways, this young boy who had these confetti-like lesions with cobularization, on evaluation, what you could see in particular with the black arrows was the CLOs, the comedo-like openings, which are characteristically seen only within the white structurous areas of extragenital LSA. You would not see them in vitiligo. The option number C and D were, of course, to twist tube. They had no bearing hair. Now, this particular image shows a lot of nail bed erythema in addition to the terminal onycholysis, which is not jagged. You can see the margins are not jagged, they are smooth, which goes in favor of psoriasis and against onychomycosis relatively. There is subungual hyperkeratosis. So this is one image which shows nail bed psoriasis. This is classical onychomycosis. This is post-traumatic onycholysis, which is also known as the roller coaster ride sign. So you can see the very sharp edges. So this is not typical. And these are thimble pits, which can be seen with non-polarized dermoscopy much better than polarized dermoscopy. So these two, that means 11.1 and 11.4, the first one and the fourth one, suggestive of nail bed and nail plate changes. So then we had this Bangladeshi immigrant. I think what I showed you were the oval caviar-like appearance, all these rounded bluish brown areas which have well-defined margins like fish eggs. They are consistent with exogenous prognosis, and that's why this patient should not be given topical hydroquinone. This patient who had been really troubled by so many, having been to so many doctors, and even I had done a biopsy also. The biopsy came back with what dermoscopy had suggested. KOH was non-contributive because of off-and-on application of antifungals as well as orals. But this is characteristic tinea of the vellus hair. In fact, this is not just vellus hair, tinea of hair everywhere, in the sense vellus as well as terminal hair. Can you appreciate the what do you call, there are comma-shaped hairs, there are corkscrew-shaped hairs, and there are barcode hairs. We have alternate white and black areas in the shaft because of the hyphal invasion. This is characteristic of tinea. So the best treatment option in this case would be, because it is tinea of the hair, vellus hair and terminal hair. That means it has gone deep enough. So you need to give treatment for at least 8 weeks, which is what we have been projecting, and terbinafine oral as well as topical. In my personal belief, cycloproxolamine and or amrolfin should be used as a treatment choice. This was a giveaway. And lastly, the girl who's complaining of severe scalp. So you can see here we have the nits which are present in every stage. We have viable, non-viable, but with operculum, and 1 or 2 empty nits. However, after the completion of treatment, trachoscopic analysis did not show any active lice, and all the nits were empty, as you can see. So this does not make me treat the patient or retreat the patient or their family. What we need to advise is the use of combs dipped in diluted vinegar, which is going to expedite the removal of the lice nits and not make the family feel that the patient has not been treated despite the mild persistent pruritus. So with this, I end this session, and I hope that everybody who attended this post test was able to get 15 out of 15. 10 out of 15 is good, 5 out of 15 is good, 0 out of 15 is also okay. There are going to be numerous chances next to learn, but you must learn. Use rated dermoscopy. Don't wait to buy a dermoscope. That's very important. And just, sir, with your permission, just 3 more points I just would like to, just mention. Number 1 was Dr. Babush kept mentioning about the fact that we have lack of literature. That is the problem. Nevosopota, for example, there is only 1 study because our study has been rejected at 3 international journals. That's why we need to build up this, and that's why we need to collaborate. Number 2, the terminology is yet not fixed. They have recently changed the terminology, including my name in that particular consensus criterion, but I don't agree with it at all. So we have to formulate our own strategy. And lastly, whenever we are showing any dermoscopic image, I would request all my colleagues to mention which is the area of the body from which it has been taken, the kind of dermoscope, magnification, and polarized or non-polarized. That would always be helpful in your international presentations or publications.
Thank you, Dr. Siddharth. Now, since we are running up shortage of time, we have a few questions from the audience. There's one important question regarding the dermoscopy. What modification do you recommend on the use of dermatoscope during COVID-19, Dr. Siddharth?
I'm sorry, sir. Can you be a little louder?
What recommendation do you recommend the use of dermatoscope during COVID times?
Oh, okay. Well, there are around 7 papers published on this issue by the same author. I should not take his or her name because he has been my mentee. Having said that, there is nothing exquisite that you need to do. If you are examining the patient face to face, you're using a dermoscope, you just have to ensure that the dermatoscope before and after the use has to be sterilized. The area which is being examined has to be, of course, cleaned and sterilized, and you have to wear sterile gloves, and you have to use a separate ice cap in case you're using a Dermalite DL4. Or the concept of polythene suggested by the same author is not, or a cling film is not something which I approve of because it distorts the optics. So if I use my video dermatoscope on a patient, I immediately give it back to my coordinator who ensures that it is sterilized and it comes back to my room only after it has been sterilized as per the protocol.
So one of the audience asking about your contact address or your email address so that they can share some interesting cases or problematic cases. So can you share your email to the audience?
Sure, sir, absolutely. So should I type it in the message for everybody?
Yeah, that will be better. And one question from my side.
Actually, it is capitalizing everything, but of course, I believe all email IDs are. This is
Dr.
one.
Siddharth, I have one question. Dr. Siddharth, I have one question for you.
Yes, sir.
How often do you come across alopecia areata and trichotillomania? For me, it's very difficult to diagnose sometimes in the children age group.
Sir, could you please repeat the question? Actually, your sound is coming a little low.
How often do you come across alopecia areata and trichotillomania in a children? I find sometimes very difficult to diagnose trichotillomania and alopecia in children age group.
As of now, I have encountered trichotillomania. I tend to see one patient in 2 to 3 months. Of course, recently, because of the pandemic associated stress and exacerbation of the tendency of impulse control disorders, I've seen more number of cases. And you have caught the pulse of what I wanted to mention. In any patient that my colleagues might see who have sustained post-COVID disease associated hair loss, diffuse hair loss, Please always scope, always do trachoscopy, because there are only 5 European reports, but I have a record in our clinic. We have a record of 26 patients who developed post-COVID diffuse hair loss, which consisted of CTE plus alopecia areata incognita, and it would not have been diagnosed unless we would have put the trachoscope and specifically over the occipital area, because it is the occipital area's involvement that differentiates the so-called diffuse hair loss versus various causes versus alopecia areata incognita. So trichotillomania and alopecia areata both are increasing in number, but alopecia areata, we should have a high index of suspicion in any patient who is coming with post-COVID delayed diffuse hair loss, especially women. I have discovered many of them have new onset hypothyroidism also detected when I got them evaluated for their detailed workup. Some of them had functional defects, some of them had very high titers of anti-TP antibodies. And this is also happening, especially after the vaccine, the Covishield vaccine, which is the vector-based vaccine. Post-Covishield alopecia areata or post-Covishield disimmune responses. Alopecia areata is the second front runner. And in such cases, apremilast is my drug of choice, because at minimal side effects except for nausea, a course of 2 months of apremilast takes care of post-Covishield psoriasis, post-Covishield alopecia areata, and post-Covishield lichen planus. I've seen 3 patients of Bell's palsy, herpes zoster, herpes simplex with lichen planus. So the combination of post-vaccine dermatosis, it is really surprising, and we are planning to publish that paper very soon. So please use your dermoscope if you find anything funny in your patient, right? So I'll just finish with that, sir, if that answers your question. And this is one website. I'm not sure of the exact spelling, but dermoscopedia.com is the International Dermoscopy Society's database. And that can also further give you references to the web pages for further studies.
Thank you, Dr. Siddharth. I have one question to Dr. Vibhus. Since you have done extensive work in facial melanosis,
yes, sir.
Have you come across a demodex or dermatitis in your work till now?
Sir, actually, no, we did not come across dermatitis, but there is one picture. I'm using another laptop where again Smita ma'am and I, we just worked it out, and we thought that those were legs of dermatitis in a case of varicose epidermal nevus. But on again looking at the further studies, those projections could in fact just be a manifestation of varicose epidermal nevus rather than the legs of the mite.
Okay, thank you very much, Dr. Vibhus. With this, I would like to thank both our speaker, Dr. Siddharth and Dr. Vibhus, who presented very nicely, wonderful presentation, very academic, elaborated with wonderful photograph. So thank you so much once again. Now I'm over to Dr. Deeptara to continue the session.
Thank you, Dr. Dharmendra, for running smoothly our webinar. I thank you, Dr. Siddharth. We are enlightened with your talk, and hope this webinar has benefited our participants. And I would like to thank Dr. Vibhus for his wonderful talk, and the whole Alchem team, especially Bharatji, Deepika, Dinesh, Sangeet, and many more to name. And a special announcement to make regarding Tinpack, who is the sole distributor of Dermalite in Southeast Asia, and who is providing the Sodvalon members participants for this webinar, and the Sodvalon Con participants with the special discounts on Dermalite. And can we have the video what Mr. Khurana has to say about Dermalite? Deepika, please. And after that, I'd like to invite our president of Sodvalon, Professor Savina Bhattarai, to give concluding remarks. Thank you.
Ma'am, I'm sorry, but I do not have the video.
Okay.
Can you share it from your end?
I have already given it. Anyway, we are running out of time also. Can Professor Savina can give a concluding remarks?
Thank you, Deeptara. And thank you, everyone. I think on behalf of the 15th Executive Committee, Sodvelon members, and on my personal behalf, I would like to thank Dr. Siddharth and Dr. Bivush for such an insightful, enlightening presentation, I should say. Like, I thoroughly enjoyed, though it was a lengthy presentation for us to stay at one place and listen to almost 2 hours, but I actually myself thoroughly enjoyed and became so insightful. And then it's been a, more, and I'm sure that all of us have learned a lot and have become more motivated to use dermoscopy in our clinical practice. I'm sure the link which was not working, I think, will be able to help our colleagues if they want to have a dermoscope at a discounted rate. And I think our committee will help them, and we could coordinate with Dr. Siddharth as well. And thank you, Dr. Dharmendra, for chairing this session. And thank you, Deeptara, for all the effort that you put in for actually making this happen. I think I should give you a round of applause, and thank you so much. Thank you, the Alchem team, Bharat and Deepika and Sangeet from Nepal, and so many others who have been, after us, after Dr. Siddharth, after Dr. Bibush, and in terms of running the dry show, in terms of making the show that is there today, because they have really worked hard to make it happen. It's all behind the scenes. And on behalf of the president, I would also like to make a small announcement regarding a few things, because I think we will be having maybe one CME in between, but we have our 16th virtual Sodvelon Con, which is going to be held virtually on the 25th and 26th of September. Dr. Siddharth has again consented to be with us. So this is just the beginning.
Part one. The official today.
Yeah, yes. So this is part one of his knowledge sharing, and we'll have more. I won't share the topic. It's going to be, I think, announced maybe sometime later, but it's going to be even more interesting. And it's going to be on a different aspects of dermoscopy in diagnosing diseases, which is, I think, we encounter more often in our clinical practice. So those who have submitted their abstracts, I'm very thankful for them. But for those who are still willing or wishing and want to present, please do so, because we're almost running to the end of the last date of abstract. We've already made a scientific present program for you, so it's going to be very interesting. And this time, it's not the conference fee is waived for all members of Sodvelon, but registration is mandatory. Please register for the CPT points that would be got after the completion of the conference. And I think I think all of us are hungry now, dinner time in Nepal. So thank you.
Dr. Sabina, we have the video ready, just a 40-second.
Okay.
We'll just run that. Okay, Deepika, can we have the video, please?
Welcome, delegates, to Sodvelon. I'm Rajesh Khurana from Timpac Healthcare Private Limited. Philosophy of Timpac is to bring products which are the best. The patients must get a treatment which is the same as in London or in New York, irrespective of their financial status. And that is how we have been selling Dermlite. And Dermlite we have with us for more than 10 years. And we are happy to state that 90% of India today buys Dermlite, and of that too, DL4.
Yes. I should say I'm also a proud user of the Dermalite 4, which comes with an attachment with all our smartphones. So it's very easy to use the attachment and then take pictures. And I'm sure we're going to flood Dr. Siddharth and Dr. Bivush's mail with all the dermoscopy pictures for, I think, so that we get better knowledge out of them. Because we've been doing a lot of dermoscopy in melasma. The research is not published, but we're trying to get more pictures with it. So I think anyone has anything else to say? Otherwise, we could, Siddharth, Dr. Siddharth?
Yeah, I just wanted to say that we need to form an alliance, formal or informal, to start with informal, but then a formal alliance is definitely on the cards, because having been a board of member of the International Dermoscopy for the past 3 years, and now I'm the fourth year as a continuation member, I have sent 27 mails to them requesting and making a case for countries which do not have a representation. For example, Nepal. Dr. Karan knows how much I have been watching for Nepal, Sri Lanka, and the entire Southeast Asia. And they would just not respond. I have requested them to make special projects for skin of color. With great difficulty, they did it. And I had 100 patients, and their 60 patients were published. I mean, so we need to be self-reliant in terms of publications and in terms of forming a protocol or a working group which really works, not just on papers. So, Dr. Samina, I think you have the power, you have the...
okay, so you can pass me on the email. Let me try my luck.
Sure, because I am very unpopular across IEDVL, of course. So, but I am always there to share whatever I know with anybody who wants to help out to the cause of dermoscopy.
So thank you so much. Thank you everyone for being part of our presentation, our endeavor of Sotvalon. I'm sure that this has made a lot of us wonder and then gain more knowledge. And I think it can also be one, as Siddharth said, biopsies should always be complementary or parallel with the diagnosis. But as a non-invasive procedure, let's sharpen our skills to learn more about dermoscopy so that we can be able to make a differential diagnosis and send the histopathologist for more diagnostic so that they can see through the different differentials that we put. So thank you so much once again. Over to Deeptara for the conclusion.
Yeah, thank you everyone for a lovely evening, for a lovely talk. And I hope this is not the last, and we have many more to come. So good night to everyone. Namaste. And
a big round of applause for Dr. Deeptara for organizing this and bringing us all together.
Yeah, it's everyone's.
Thank you so much.
It's everyone's effort.
And I'm so sorry for giving you a heart attack yesterday.
Don't give us a heart attack on the 26th as well, Dr. Siddharth.
Oh, no. I never do that. I'm just, so embroiled in what I'm going to present, making last minute changes. So that's it. I'm so sorry for that. But then each time I take a vow that this time I will be prepared. My presentation will be ready 2 hours before presentation. It never happens. My presentation is stuck, ready just before my talk. But I'll ensure that I don't trouble you that way. Surely.
Okay. Bye-bye.
Thank you, everyone. Good night.
Good night. Take care. I'll mail my presentation in the form of a PDF to Dr. Deeptara. You can please feel free to share it with the entire Sotvalon